Get used to that vocabulary. Just figure it out now. Get used to that vocabulary. Supraventricular rhythms are sinus, atrial, and junctional. Get used to that verbiage. Get used to understanding when someone says an SVT, that in your head you know that that's a supraventricular tachycardia, which means it's a tachycardia that's happening above the ventricles, which means it has to be coming from the sinus node, the atrial node, or the junction. One of those three. Does that make sense? It has to be, because it's supraventricular. Don't just walk through this life of EMS not understanding what those words mean anymore. Make sure you know. Andrew.
So this brings me to a question I've had for a while. So sinus tach is a supraventricular tachycardia?
Correct. That is correct.
Okay.
Okay, so let's talk about supraventricular tachycardia and SVT. SVT is in relation to like ACLS, is a condition that we are treating. SVT is also a catch-all term. It means two separate things. It means something from the A&P, the anatomy and physiology side of EKG, and it means something from the clinical side of EKG. From the anatomy and physiology side of EKG, it is anything, any tachycardia, no matter what the rate is, that is not coming from the ventricles. From the clinical side, SVT is a tachycardia that you can't tell what it is, but you can tell that it's above the ventricles.
Because it's going fast enough that you can't see all
Correct.
that.
Because you can't see all the components, so I can't say, well, is this really sinus tach or is this atrial tach? Or is this a junctional tach and the P wave's hidden inside the T wave and the T wave is tucked right up against in between those QRSs and I can't really tell. So it's I can't really tell, so let's treat it.
What is it? Narrow QRS. Like, there's no way you can come from the ventricles.
Correct. So if I've got a narrow QRS tachycardia, it's an SVT, no matter where it comes from. Now that being said, if you're analyzing EKGs, it is not appropriate for you to put SVT if you can tell what it is. Does that make sense? If you can't tell what it is, or it could easily be one of a couple of different ones, depending on something that you can't see because it's going so fast, then it's appropriate for you to call it an SVT. Does that make sense? So basically, if I see two QRSs and one wave in the middle, well, likely that's the T wave, but where's the P wave? Is the P wave buried in it? Is there no P wave and it's a junctional tach? I don't know. That would be appropriate for you to call it an SVT because you can't tell. Does that make sense?
Yeah.
And we're in an interesting dilemma right now in all of EKG treatment. The exact treatment for specific EKGs is a little different. But we're also in a state of, we've got an industry that was not really good with EKG to begin with, and we're just building into that. And so there's a faction of people that believe we should try to treat everything as generically as possible. Therefore, treat SVTs. There's another faction of people that believe we should have specific treatments that are keyed to those exact rhythms, because there are differences in how we might treat those. And those factions are warring, and we're somehow stuck in the middle. So right now we are more along the lines of treating the generic thing first, treating the SVT to get them stable, and then move to treat the more specific rhythm down the road after we get them stabilized. Does that make sense? But there is some warring right now on exactly what we should be doing, and there are differences in opinions on whether or not we should be treating the exact rhythm or whether or not we should be treating the general rhythm. So just understand that. And you'll hear that, right? You're gonna have some preceptors that are, you don't need to know any of that, just treat it like this. And they're generalists. I just made that word up, so it's not real, right? And then there's other preceptors you're gonna have that are going, no, tell me what that rhythm is, because you need to know, because there are some differences in how we might approach this patient based on what their underlying rhythm happens to be. Good? I would argue that I'm slightly on that side of it than on the generalist side. Okay? Which tells you something about you needing to know your rhythms. Okay. Okay, so sinus, atrial, and junctional rhythms are all supraventricular, and then we have the ventricular rhythms, right? Okay, so when we have sinus rhythms, they're all the ones that originate from the SA node. They all have P waves that are identical, and they all have PR intervals that are the same. That's what's common amongst all sinus rhythms. They have P waves that are all identical. They have PR intervals that are all the same. We can go a step further and talk about what those P waves are supposed to be shaped like in specific leads that we're looking in. And please, please, please get used to doing that, right? So Shannon said, I've got upright P waves. That's not enough, right? That's like saying, I'm giving them oxygen. Okay, how are you giving them oxygen? Am I giving low flow, high flow? Am I giving nasopharyngeal on a breather? How are you giving them oxygen? In this case, it's where are we seeing those upright P waves? Because if you're telling me I'm seeing upright P waves in AVR, we've got a problem, right? If you're telling me I've got upright P waves in V1, I need to investigate that a little bit further. If you're telling me I have upright P waves in lead 2, okay, that makes sense to me, right? So note what you're seeing and what picture you're taking it from. So get used to using the leads that you're looking at that, the camera that you're looking at that in. Good? So a normal sinus rhythm then, oops, I'll go here first. So of all of them, when we're looking at the difference between, we only have 4 sinus rhythms really that we're looking at. It's either a normal sinus rhythm, we could say we've got 5, in that we'll strike the word normal if we have crap mixed in, right? So in a no crap rhythm, it's either normal sinus rhythm, sinus brady, sinus tachy, or a sinus arrhythmia, right? That's all review, you're all clear on that? Or at least that's all, oh yeah, I remember talking about that yesterday.
Yeah.
Fantastic, okay. Only difference between the normal sinus rhythm, sinus brady, and sinus tachy is the rate. It's either between 60 and 100, less than 60, or greater than 100. Good? If it's a sinus arrhythmia, the only difference between the sinus arrhythmia and the normal sinus rhythm is what's happening with the rhythm, whether or not the rhythm is regular or irregular. Good? We go a step further on the arrhythmia to determine if it's a regular irregular or irregular irregular. And if it's regularly irregular, what's it going to be based on?
Pathology.
If it's regularly irregular, what's causing it to do that? What's it going to be based on?
Breathing.
On breathing. That's right. It's going to be based on their breathing. So you'll see the pattern with their breathing, right? If it's irregularly irregular, then it's pathologic. So from the normal sinus rhythm side,
You said it speeds up when they breathe in, slows down when they breathe out.
correct. Yep. You'll see it immediately after. So they'll breathe in, and that'll cause it to speed up, but it'll be speeding up. They'll be done breathing in when you're seeing it speed up,
Okay.
right? So it's immediately after, but it's based on that pattern.
Okay.
So if we're setting up our parameter, this is what we are comparing everything to. If a normal sinus rhythm is here, the rate's between 60 and 100, the regularity is regular, the P waves are present, and sinus with all the parameters that we just talked about. The PD-QRS ratio is 1:1, the PR interval is normal and equal all the way through. The QRS width is less than 0.12 or less than or equal to 0.10. There is no grouping and there's no drop beats, meaning there's no things that are coming together without something that's supposed to be in between, and there's no missing QRS complexes in there at all, so there's nothing that's happening that's making it weird or strange, which is a way of saying there's no crap built into it. That would be what normal is, and that's what we compare everything else to. Right? Okay, so sinus bradycardia and normal sinus rhythm. The sinus bradycardia and the normal sinus rhythm being less than 60 or greater than 100 can be their own rhythms, or bradycardia and tachycardia can be a portion of crap. So I gave you a cheat sheet yesterday, and on that I listed a bunch of crap. You realize that crap is not a medical terminology, right? Okay, good.
Talking to the doctor and be like, wow, there's a lot of crap here.
Yeah, exactly.
Excuse me?
Well, that's what Cory said we're supposed to call it.
Crap.
Bradycardia and tachycardia can be something that's crappy within the rhythm, and so can arrhythmia. So we've got a little bit of subjectivity that has to come into it. So when I'm talking about a sinus arrhythmia, just the word sinus arrhythmia will be between 60 and 100. Everything is the same as the normal sinus rhythm, except for the regularity, which will vary based on respirations, or it could vary on other bad stuff too, but it'll vary on respirations. It can also be a sinus bradyarrhythmia or a sinus tachyarrhythmia. Does that make sense? So if someone starts with an arrhythmia and then they have sympathetic involvement or parasympathetic involvement, it can either be fast or slow. So we can have a sinus arrhythmia, or we can have a sinus bradyarrhythmia, or a sinus tachyarrhythmia. Does that make sense? And in that case, the brady and the tachy are crap built in with this arrhythmia that we have here. So the sinus arrhythmia can be within the sinus rhythm, the sinus brady, or the sinus tachy. It could be any one of those can happen. Good. So most of the time, it's based on the respiratory cycle, and there's nothing else that we need to do about it. Sometimes it can be a pathology, and we will kind of discuss that as we go. So as we start to get into some of the pathologies, we'll say, okay, they might have a sinus arrhythmia that comes from this. But most of the time, it's a normal variant in people who are healthy. The healthier you are, the more of an arrhythmia you tend to have. Okay? And in fact, it's not just an arrhythmia. What kind of an arrhythmia do you usually have the more fit you are?
Bradycardia.
A bradyarrhythmia. Yeah, you most commonly have a bradyarrhythmia. Right? Make sense? Okay. With the sinus bradycardia, a couple things to maybe pull out that are just there. When you have a sinus bradycardia, do be aware that if you have a serial EKG and you can see their normal EKG, the differences will be not just in the expansion of the P to P interval and the R to R interval, but you tend to also have an elongated PRI as well. And why is that? No, when I say elongated, I just mean on the large side, the high side of normal. I don't necessarily mean extended beyond that. But why? Why would you have a greater PRI than in a normal sinus rhythm in the same patient?
You're slowing down.
I gotta have a lot more information.
Signal travel slower?
Parasympathetic involvement,
And what's it doing?
slowing down the heart,
Slow
And
down everything in the heart.
how would slowing down the heart change the PRI?
conduction,
So
or its
give me more
excitability. Like it's not as excitable, I guess.
It's changing the voltage that the IF channels open and close. So it's making that
Great.
voltage
How does
more,
that change the PRI?
I don't know if that would
because
change
as
the
it comes through the AV node is going to hold that signal longer before it passes it on
Good.
through the bundle of his to the Purkinje fibers.
Okay, so get used to knowing where the ANS, the autonomic nervous system, is affecting the heart, right? We briefly did this when we had a massive discussion on the last exam, right? Or 2 exams ago, I don't remember which exam it was, right? But
It was the last one.
The sympathetic system affects those beta-1 receptors on the autorhythmic cells, which is, we'll start with the SA node and the autorhythmic cells of the atria, which make them more excitable, and that increases the rate. But in the AV node, what it does is makes the AV node less convoluted. It opens up more channels so that it speeds the conduction through the AV node. So therefore, the sympathetic involvement would do what to the PRI?
Shorten it.
It should shorten it a little bit. Does that make sense? In other words, the P wave, the atria depolarizing, and the QS complex, the ventricles depolarizing, will be closer together, right? And that's also accomplished without causing problems, because that would typically cause a problem because we've got the atria being in its refractory period, and then the ventricles in the refractory period. But if we're speeding up the heart rate, then would the ventricles be jumping on top of the atria? What kind of problem would we have here? But we also know that the ventricles do what, or that the sympathetic system does what else? Besides increasing the heart rate and increasing the conduction rate. What else does it do?
Contract.
Related to what I'm talking about here, what else does it do?
It makes the refractory time less so that it
By
can,
speeding what?
by speeding the exchange of calcium ions.
Okay, let me ask you a different question. When it's quickening when it's shortening the refractory period, that results in speeding what process?
Repolarization.
Say it loud.
Repolarization.
It speeds repolarization, right? It's increasing repolarization. Does that make sense? Therefore, the cells are ready faster. Therefore, we can have the P wave closer to the QRS, and they'll be ready to fire faster as well. And then that fourth thing that that sympathetic system does, which is independent of those, is the strength and contraction, right? Increasing calcium entry to have a stronger stroke volume, to have a stronger contraction and a greater stroke volume. It also happens to increase the rate of the calcium ATPase pump, which is going to do what? Where's the calcium ATPase pump?
Is that in the in the SR?
It is, and what's it do?
It pumps the calcium back into it.
So therefore, if it strengthens contraction, what else is it doing?
Getting ready for the next contractions.
Yeah, it's relaxing the muscle faster as well, right? So the sympathetic system, for all intents and purposes, makes the heart work faster, but also resets it faster as well, so that it's ready to work again. Does that make sense? Okay, the parasympathetic, on the other hand, where are muscarinic receptors found, primarily?
On the SA node?
SA and AB.
On the target organ?
Yes, on the target organ. We are talking about one specific target organ right now, which is what?
The heart.
Good, so where's it found on the heart?
SA and
SA
AB.
and AB.
SA node, AB nodes, so what kind of cells are those?
Autorhythmic?
On autorhythmic cells. Is it found on contractile cells?
No.
No, it's really not. In very low abundance on contractile cells. So how much effect does the parasympathetic system have directly on contractility?
Little.
Very
Basically
little.
none.
Yes, the effects on contractility are all indirect effects on contractility, right? If we lower the heart rate and we lower the conduction volume, and we get rid of the sympathetic system, we're going to reduce our stroke volume, so therefore we're going to reduce our contractility, but that's not a direct effect, that's an indirect effect. So the direct effects of the sympathetic system are what? Of the parasympathetic system are what?
Slow down
Like
the
rate
rate.
reduction.
Slow down rate
Conduction.
and slow down conduction. And therefore, what's going to happen to the PRI?
Can it
Increase.
Because why?
It takes longer to
Slower
reset.
at the AV node.
Because what?
There's a conduction delay at the AV node that's longer because
Good.
Less available pathways.
There you go. So we have less channels open throughout the AV node cells. Therefore, the movement of ions through the convoluted AV node is less speedy. It takes more time. Therefore, there's more delay. Yes.
Can you just repeat where you'd find the adrenergic receptors then?
Beta 1 receptors? Yeah, where are the beta 1 receptors found? Where are beta 1 receptors? Adrenergic receptors, what is she saying?
on the SA, AV, and then also on the autorhythmic cells?
SA and AR
Contractile-
autorhythmic cells.
contractile
On the
cells.
In the AV.
So pretty much everywhere in the heart.
Good, so
Yeah,
they're
everywhere.
found on most of the heart cells. On the autorhythmic cells, they're found specifically on the IF channels. They are also found on independent sodium and calcium channels on those autorhythmic cells to make them more excitable and faster to depolarize, which makes the rate go up. In the AV node, the primary job of the AV node is to delay the signal, right? So we're opening more channels throughout the AV node to speed the ions through the AV node and therefore lessen the delay. Then they're found on the contractile cells, specifically on calcium channels, to introduce calcium to depolarize the contractile cells faster. to introduce more calcium into the cell itself, and therefore will have more actin and myosin coupling, therefore it's a stronger contraction. It's also speeding the work of the sodium potassium ATPase pump and speeding the calcium ATPase pump to reset and to pull that calcium out so it relaxes faster and repolarizes faster. That's all sympathetic mediated.
Did you ever talk about how the AV node delays the signal?
We didn't, in fact, I skirted it on purpose because it convolutes everything.
It's too complicated
There are
for
lots
us.
and lots and lots of AV nodes.
Bless you.
The cells within the AV node have a whole ton of channels, and there's either more or less of them open. When there's more of them open, we are depolarizing those cells faster, and the movement of ions happens faster. If we close up those channels so that less ion can get in, it takes longer from cell to cell for it to reach its threshold. Therefore, the movement of ions is slower as it moves from one cell to the next throughout the AV node and getting through that mess of cells into the blood organs. People have tried to make their career on studying the AV node. Good? Questions? Okay, so when we look at the sinus brady versus the sinus tachy, it's all related to what the sympathetic and parasympathetic system is doing, and we see differences in the PR interval as well as the P to P and R to R intervals. P to P and R to R intervals should still match. Okay? That being said, even in the sinus arrhythmia, even though the R to Rs do not match the R to Rs, does that make sense?
Can you say it again?
The R to Rs do not match the R to Rs. In a sinus arrhythmia, let me move to a sinus arrhythmia.
So there's some funkiness.
Because it's irregular.
Yeah, in a sinus arrhythmia, the R to Rs do not match
Yes.
because it's an arrhythmia.
Yeah.
The P to Ps do not match, right? But the P to P to its specific R to R does match. Does that make sense?
And
Yes.
the PRI is
So this P to P will match this R to R. This P to P will match this R to R, even though this P to P will not match this P to P, and this R to R will not match this R to R. Does that make sense?
Yes.
But my P to Ps are still matching their corresponding R to Rs.
That's how you can tell it.
That's how I can tell that.
That's how you can tell that it's
An arrhythmia.
So in conjunction with that, if you have a rate that's all the regulated P waves and QRS ratio, all that stuff is where we want it to be, it's all normal. And we have a rate between 60 and 100, and we go to caliper everything out, and we're noticing that our P's aren't matching, and our R's aren't matching, but our P to Q's and P to Q's are matching. It's the sinus rhythm without any sort of other, ectopy is not the right word, we can denote that it's something, it's an arrhythmia and not some other underlying issue.
You used some interesting words there, so I'm not positive I know what your question
I'm
is.
not
Try again.
positive I know my question is either.
Try again.
So, taking everything into account that we have up there, everything is normal. If we have a sinus rhythm where everything is normal,
Okay.
yet when we go to do our caliper out of P to P's and they don't match,
Yes.
and we go to caliper R to R's and they don't match.
Yes.
But we notice that P to Q's match down the
I don't
line.
know what you mean by P to Q.
Your
PRI?
P to the subsequent Q, QRS segment.
So stay with the right, stay with the same letter, R.
B to R.
I'm sorry, PRs.
Good, so B's
Yes.
match B.
Yes, so
Yes,
if our rate is between that 60 and 100, we can basically denote if everything is normal that it is an arrhythmia and not some other line
Correct.
issue.
that's correct.
Okay.
That is the definition right there of a sinus arrhythmia. You'll go one step further now, and you'll identify, is this sinus arrhythmia Because the only difference now is in that regularity. You just defined a new arrhythmia. So now we need to know, is this sinus arrhythmia, does it have a pattern to it based on breathing? Or does it not have a pattern to it, in which case that would be pathologic? Something is wrong with the person.
So is the one that's showing on the board there, is that a?
We wouldn't know,
You don't see it.
because we
We
don't
don't have enough info.
We don't have enough. Yeah, we have to have more to see, because this is getting faster each time. We'll need to see it come back down. I mean, sorry, this is getting slower as we go. We need to see it come back to
Okay.
fast, and we need to compare that to what we're assessing of their respiratory system.
Okay. So
Because
if
then
you
we'll see
notice,
the pattern.
if you had like an 18-second strip and every 6 seconds matched the next 6 seconds, that would be,
Then we'd start to see a pattern.
okay.
And then we want to see that that pattern matches their breathing,
Okay.
which you can do on your monitor, right, if you're doing end-tidal CO2, or if you've got an SpO2 monitor that is monitoring their waveform, then you'll note the waveform of their breathing will match the waveform of their EKG.
Okay.
Because now, so you guys have been learning up till now a whole bunch of, it's like in A&P, right? When you took your A&P class, you learned things in a 1-to-1 ratio. Like, here's what 1 sodium potassium ATPase pump does. And here's what 1 sodium channel does. But at no point in time, my suspicion is that your A&P instructor probably didn't come to you and say, this one cell has hundreds of sodium channels and hundreds of potassium channels and thousands of sodium potassium ATPase pumps all working in concert. And they probably didn't talk to you about the fact that when you talked about your heart cells, and you all learned beta receptors and muscarinic receptors, I know, because it's part of A&P, even though you might have forgotten. But they probably didn't ever really define to you that this one heart cell has both beta receptors and muscarinic receptors. And they probably didn't mention that there are literally hundreds of both of those, nor did they probably talk to you about the fact that we've got epi, or norepi, and acetylcholine both affecting it at the same time, and it's the net that we actually see.
So long
Right?
as it's on
Yes, and now I'm asking you to combine all those things. And in the same vein, in EMT, you learn, okay, here's what my SpO2 is. Scratch that. Here's what my end-tidal CO2 is. Scratch that. Here's what an EKG is. And now I'm asking you to put the EKG on top of the end-tidal CO2 and the SpO2 and see the relationship amongst them. Because we're integrated. It's not independent. All of those things come together. They mean something separately, but they mean something together, right? My SpO2 separately tells me how my oxygenation is. My end-tidal CO2 separately tells me what my metabolism is. My EKG separately tells me what my heart's doing. You put those three things together and it's telling me that my patient has got a breathing problem that's affecting their EKG, that's affecting their heart. And we start combining those things together to see, this is what's happening with my patient, right? So you're being asked to take something to the new level, to a new level. Y'all get that? Okay. King County, Washington, I think I probably told you. Did I tell you what they wear in King County?
The doctors.
Yeah, in King County, Washington, their paramedics wear doctor smocks, and that's coming from a whole bunch of doctors many, many years ago who took a look at what paramedics had to do and went, this is what we learned in third-year medical school. So therefore, we want you to have that professional look because that's what you're professionally doing, right? You understand what the word paramedic means? What does paramedic mean?
Alongside.
Somebody nearby a doctor. It's a para-
Yeah, it means pertaining to, IC, near doctor, right? Do you know how paramedics came about?
More. Yeah.
Did you
They
watch
were morphed
Emergency?
from doctors. In England, they put cardiologists on ambulances and sent them out in the field. And then they found out, this is really cool because patients are really getting good cardiac care, but we've got a little bit of a problem in that they're not in the hospital. So now they're seeing single patients, one after the next, in the field, but at the hospital, they could be doing rounds and seeing more people. So the question became, Well, what do they do out in the field, and can that be taught to somebody that isn't a doctor to allow them to do what's they're being done in the field and keep the doctors in the hospital? So you gain doctor skills, you were called paramedic, and then you're stuck out there to do this work, right?
So why are paramedics often considered less than nurses?
Because that's our industry. Our industry is young, and the nursing industry is not young. And there is a kind of a perpetual view of paramedicine that's kind of rampant across the country. That's also specific, geographically specific. That's not the case everywhere. Some places, the respect towards paramedics is incredibly high, and in other places, it's a lot lower than what you even see here.
Okay.
Just depends on where you go.
Because I thought it was pretty lame. Like the nurses don't treat. I don't know. You just go in there, wait for the doctor, and then the doctor's like, I don't know. I thought that was
They do
lame.
go to a lot of school too. You go
Yeah.
to, I mean, if you're,
Yeah.
if you have a BSN, they went to more school.
Yeah.
Yeah, there's a standard BSN standard.
There's also a difference in the way that the training came about. Right? We are slowly moving towards a process that nursing has been at for many, many years. Right? But nursing has been around since Clara Barton, who started the Red Cross 200 years ago. And paramedic has been around for 50. Right? Since 1966. Okay.
Also know about whose care is more or less. You're all treating patients.
Okay. So we talked